In Rwanda they say Mwaramutse and they follow it Amakuru. The Rwandans on the call can understand and feel free to respond in the chat. So here finally comes the third day of the TORG plus King Faisal Hospital of Rwanda Scientific Conference, which is also an opportunity for us to celebrate the 10th anniversary of the Operating Room Global, which is a movement that has created so much impact in the past years. Drum rolls for the Operating Room Global in the chat, please. So we can't start this day without acknowledging and celebrating the immense support that our partners and collaborators put in to ensure that this event is a success. So we obviously acknowledge the King Faisal Hospital for their immense support. We acknowledge IRCAD Africa. We acknowledge the Medical Student Association of Rwanda, who did a great job at as protocol, and every other person who contributed directly or indirectly to making this event a success. So without further ado, I'm going to introduce the moderator of our first panel discussion for today. So we're going to be having a panel discussion titled Innovation in Surgical Technology and Sterile Processing, Enhancing Patient Safety. And the moderator for this session is Dr. Raza Khan, who I'm going to introduce immediately. So Dr. Raza Khan is, I'm going to introduce you, Dr. Raza, then you take over. So
thank you.
Dr. Raza Khan is a PhD fellow with a dual Masters of Science and MBA in Health. He holds a diploma in patient safety and 6 black and green belt certifications. He serves as chairperson of the Operating Room Global Pakistan chapter and brings expertise in patient safety, healthcare systems, and surgical process optimization. Dr. Raza Khan, it's such a pleasure to have you here today, and you can go ahead and introduce your panelists. Over to you, Dr. Raza.
Thank you. Thank you for this wonderful introduction. My name is Raza Khan, and I would like to introduce my panel members. Our first member is Dr. Tariq Zafar, who is the patron-in-chief and advisor of the Operating Room Global. Dr. Tariq Zafar holds MBBS, FCPS, and MHA, and he is a trauma and general surgeon from Armed Force. He's the senior healthcare management professional, and he delivered trainings over decades in various institutes, including Dow University hospitals and other. And he serves as also advisor and consultant in hospital planning, design specialist. He's working currently with Dow University and Pakistan Institute of Management Sciences as a lecturer in healthcare management. So Dr. Tariq Zafar Saab, are you here? Okay. So our second panel member is Ms. Beenish Islam. She's assistant registrar, and she is allied health professional at King Edward Medical University, Lahore, and where she serves as a lecturer, coordinator, and clinical preceptors. He holds BS honors in surgical technology, and he is also the editor-in-chief of TORG magazine. She also holds currently pursuing diploma in artificial intelligence in healthcare. Ms. Beenish, are you here?
Yes, I'm here. Assalamu alaikum. Thank you for the introduction.
Okay, thank you. So our third panel member is Mr. Zakir Hussain, and he's from India. He is currently working as assistant professor and program coordinator in OR technology at Brainware University, India. And he is also the chairperson of the Operating Room Global India chapter. Dr. Professor Zakir Hussain, are you here? I think he's Okay, let's move on. Next participant, while he's joining, Mr. Hafiz Abdul Mannan from New Zealand. Currently, he's New Zealand based, and he was from Pakistan, and he also worked with Qatar. He holds MS in Quality Management, and he is a CRCT certified. He is also a qualified professional in the CESSD. He serves various institutes in various countries. And formerly, he was the manager of CSD at Lahore Hamid Latif Hospital. And currently, he is working at New Zealand. Mr. Hafiz Abdul Mannan sahab, are you here?
Yes, very thank you, Mr. Raza. I am here.
Thank
Very
you.
thank you for my introduction.
Thank you. And our fifth panel member is Muhammad Akhtar. He's currently Kuwait-based and from Pakistan. He's allied health professional and certified professional. He holds BS honors duty in operating room technology, and he is also working. He's experienced in the theater management and currently working as a theater manager. And he's a special project coordinator for the operating room global Pakistan chapter. Mr. Muhammad Akhtar Saab, are you here?
Yes, sir, I am here. Thank you so much.
Good, thank you. And our last panel member is Mr. Junaid. He holds BS honors degree in medical technology. He also did MBA in healthcare and hospital management, and he is expert in robotic laparoscopic surgical technology. Mr. Junaid, are you here?
Yes, I'm here.
Okay, thank you. Thank you for all panel members for being here. So can we move to our first round of the questions?
Sure, please go ahead.
Okay, Dr. Zakir and Dr. Tariq Saab, have you joined? Okay, so our first question is from Ms. Beenish Islam, and we would like she to respond on the question, how can innovation in surgical education and artificial intelligence be integrated into surgical technology training in low income or low resource settings?
Okay,
Yes,
in your question, you mentioned surgical technology and low resource country. Let me first paint the picture of a low resource country, the developing country. We have conventional OTs in Pakistan or in other developing countries. By saying conventional operating rooms, I mean an operating room where all the information is paper based, like the monitoring devices and all the readings are not connected with each other. The devices are working in isolation, and we have wires all around the floor, and every information of the patient, including the pre-op, intra-op, and post-op, every reading is on the paper. So if you want to integrate artificial intelligence in such circumstances, I'm particularly talking about that, especially in surgical technology as well, we need to first digitize the data. Digitization is the first step. How can you convert a conventional OT to AI? First of all, there are AI software tools. For example, for there is a tool called OCR. This is optical character recognition. We need to extract the data and convert the paper-based data into a soft form. Through this software, this OCR converts the data by taking pictures of the papers, pictures of the documents and files. We can convert the hard data available in hard copy in a soft form. So this is the first step. Secondly, we can use this data after digitization of all the investigations, of all the information monitoring systems. We can use this data for image analysis and classification. Image analysis and classification will help us in disease detection, measurement of the lesions, and classification of the disease according to the extent and the severity of the disease. So this can help us in predictive analytics. So, and the next software that is very much useful is the decision support system. Clinical Decision Support System. CDSS is another AI-based tool which can be used for remote consultation and second opinions and image sharing and telemedicine as well. So somehow all these things are connected to surgical technology as well. Surgical technologists' main primary job is infection prevention and control, and they're involved in pre-operative, intraoperative, and post-operative care of the patient. So somehow, and especially the inventory management as well. There are many softwares. When you convert your data from hard form to a soft form, you can manage even the inventories. It can keep a record of how many supplies has been used, how many drugs has been used. So all the workforce that you were using in managing and writing everything in the registers, they can directly be engaged with patient care. So this is the first step of using AI integration in conventional operating rooms. And second step could be the AI-powered simulation and virtual realities. We need to first learn AI tools is integration and then develop some simulations. We need to develop and utilize low-cost virtual reality and mobile-based simulation platforms. These tools allow surgical technologists to practice and refine complex skills like instrument handling, spatial awareness repeatedly without the need of expensive physical labs or cadavers. For example, virtual reality modules could simulate the steps of laparoscopic procedure, providing real-time feedback on instrument movements. And secondly, we need to design some large language models for knowledge dissemination. Utilize large learning models to create personalized study guides, generate quizzes, and answer complex questions. So this is a comprehensive answer. I hope I answered your question. This is how we can integrate AI into surgical technology in a low-resource country. Thank you.
Thank you, Ms. Beenish, for this wonderful response. And you provide very practical suggestion to the question. So have Dr. Zakir, Hussain, Parray join us? Dr. Zakir, are you here? Okay, so I think Dr. Zakir is not here. So we shall keep to the next panelist, Mr. Hafiz. Okay, so welcome, Dr. Zakir, to the session. So my question is to you, what do you think, what role do operation theater technologists play in patient safety, and how can training programs be enhanced to support that role? Over to you, Dr. Zakir. Dr. Zakir, your mic is unmute.
Hello, am I audible now? Yeah.
Yes, now you are audible.
Okay, thank you so much. It's a good question, basically. Operation theater technologist's role in playing the patient safety. Operation theater technologists are the very heart of patient safety in the surgical environment. While surgeons and anesthesiologists perform the procedures, the technologists are the ones who create and maintain the conditions for safe surgery. So their responsibilities start well from the first incision, checking sterilization, ensuring functionality of anesthesia machines and monitoring equipment, preparing OT according to infection control standards, and verifying patient identity and surgical site. So they play a very crucial role in patient safety while dealing with some of the cases in which there are disruptions or there are some distractions so that we can't focus on the things. That time, operation theater technologies plays a major role in patient safety. During the surgery, their vigilance prevents contamination, equipment malfunction, and delays that can compromise patient outcomes. They are the bridge between technology and clinical care, making sure the operating room runs smoothly, efficiently, and safely. Because before starting the procedure, they make the equipments ready. Depending upon the surgical procedure, they can withstand They can be available for a huge period of time, whether the surgery is complete. After the completion of surgery, they will be there for checking the patient safety, whether the vitals are normal or do we need any other observations of the patient. So they are playing a very critical role in patient safety. During the surgery, after the surgery, in post-operative care, sometimes the post-operative nurse will go and check the vitals of the patient. However, to truly empower them, our training programs need a paradigm shift. Traditional models often focus heavily on technical skills, but patient safety demands more. We should integrate simulation-based learning to practice crisis scenarios like equipment failure on or unexpected need without risk patient safety. Anesthetists and nurses under pressure. Competency-based assessments, we can go in a state of purely knowledge-based exams, ensure graduates can apply skills in real time. We can go for continuous professional developments, like in academics, we are going for faculty development programs. In hospitals, basically focusing on operation theater technologies, we can go for continuous professional development. Since surgical technology involves rapidly robotic surgery, artificial intelligence assisted monitoring, and advanced infection controls practices are already changing the operation theater landscape. If we invest in these areas, OT technologies won't just assist, they will active safeguard patient as equal members of the surgical team. Thank you so much, sir.
Nicely respond. Thank you, Professor Dr. Zakir Hussain. So I would like to ask next question from our panel member, Mr. Hafiz Abdul Mannan Sahab. Mr. Hafiz Abdul Mannan Sahab, based on your international experience, what the key lessons in this trial processing that LMICs can learn from the systems in New Zealand or Qatar?
Very thank you so much, Mr. Raza Khan. This is a great opportunity to share my experience as I have my first experience in Pakistan and second was in Qatar, and now my updated and current experience in New Zealand. Actually, I will share 2 or 3 key lessons in sterile processing that is comparatively in Pakistan, New Zealand, and Qatar, and also comparison with low and middle income countries. First, my point is there should be a strong regulatory standards and compliance. If I give the example in New Zealand, there is mostly Australian and New Zealand standards. They are followed. For example, the previous one was the 4187 that is published in 2014, but it's now a new updated version that is Australian standard 5369 that is published in 2023. In New Zealand, they follow the standards for the reprocessing of medical device. And if I discuss of Qatar, they follow mostly the Joint Commission International Standards. And they also follow the Ministry of Public Health Qatar for the reprocessing of surgical devices. But if I discuss for the low and middle income countries, according to my opinion and experience, I think there is a very useful for the reprocessing, that is World Health Organization standards. And they are a little bit flexible and there is a not too much strict rules and regulation that is better for low and middle income countries. And my second opinion for the key lessons as investment in workforce for the education and certification. As in New Zealand, there is a New Zealand Sterile Science Association. They give the different certification in CSST. For example, Here is level 3, level 4, and level 5 CSSC certification. And in Middle East, in Qatar, UAE, there was HSPA, there was a CRCST, CIS, and different certifications for the CSST. And if we discuss for the low and middle income countries, they should give the hospital training, hospital short courses, and they should affiliation with the HSP and CBSPD, because already HSP and CBSPD already working in a chapter in, also they are working in Pakistan and different nationals. They have a good platform. And last one, my opinion, is the implementation of traceability and integration of infection control and management system. Because here is a little bit advanced system that is a barcode system and tracking system, that named as TDOC system for the tracking the instrument in CSST. But if there is nothing, any system, they can follow the any badge label system, color coding system, and for the traceability of the surgical instrument. So I think this was the parameter according to my experience to for the key lesson in sterile processing technician. Very thank you so much. Mr. Raza, your mic is muted.
Thank you. Thank you, Abdul. So I would like to ask a question from next panel member, Mr. Muhammad Akhtar. Mr. Muhammad Akhtar, are you here? What strategies have you implemented as a theater manager to ensure infection control practices and optimize workflow in the OR?
Thank you so much, Mr. Raza. As a theater manager, I have focused on strategies that address both infection prevention and workflow optimization, since the two are deeply connected with each other. So first, I will discuss about infection control. So there is one strict adherence to evidence-based sterilization protocol with routine audits to ensure compliance. And second one is the zoning with the OR complex to separate clean, sterile, and contaminated areas, which minimize the cross contaminations. And third one is the regular staff training and stimulations drill on aseptic techniques, hand hygiene, and emergency contamination scenarios. So if we discuss about optimizations, then I would like to introduce case cut system tailored to each procedure, reducing unnecessary traffic in and out of the OR. So there is a standardized protocol that streamline turnover while ensuring sterility is never compromised. So close collaboration with anesthesia, nursing, and sterile services department. So we anticipate need in advance rather than reacting during surgery. These strategies together have reduced delay, improve staff compliance, and most importantly, lower the risk of surgical site infections while enhancing patient safety. So at the end of the day, the greatest innovation is not the technology itself, but how we integrate it to ensure that every patient leaves the operating room after safer than the entered it. This is our first priorities that we have. Thank you.
Thank you, Muhammad Akhtar. So my last question is from Junaid Khan. How is robotic and laparoscopic surgery reshaping the skills requirement for surgical technologists in LMICs? Mr. Junaid. Mr. Junaid, are you here? Okay, so now we can move on to our second round, and we will park this question for later. So my question is from Miss Beenish Islam. Uh, what's the what's the future of minimally invasive surgical technology in low middle income countries, and how can educators prepare students for it? Sorry, we are running short of time, so we have now 3 minutes for each question to respond, 2 to 3 minutes. Ms. Binish.
Okay, Ji, I'll talk about education first. Again, I want to emphasize that we all need to learn AI and then implement AI. So I'll start with the simulation-based curriculum. Previously, we had some workshops on AI because when we were buzzed about the AI 2-3 years back, but now in King Edward as well, we are trying to integrate it in the curriculum. So integrate a structured curriculum that utilizes simulations, whether they are low fidelity physical models or the AI-powered virtual systems mentioned earlier. This allows for repeated practice and objective assessment, building proficiency before a student even enter an operating room. Second are the areas like foundation skills. We need to emphasize the mastery of fundamental skills using low-cost box trainers. Here in King Edward, we presently have the box trainers, and these trainers are inexpensive and highly effective for developing hand-eye coordination, depth perception, instrument manipulation skills, the core component of any minimal invasive surgery. Third important area is the training in maintaining and troubleshooting. We need to train students not just on how to use equipment, but also on how to maintain and troubleshoot it. In low resource settings, broken equipment can bring a surgery to halt. The ability to perform basic repairs and identify issues is critical skill. So this is the precise answer that you wanted from me. Utilizing this platform and being the editor-in-chief of the Operating Room Global magazine, I just want to thank all my contributors, those who contribute in the magazine. I want to just thank you face to face. Thank you very much.
Thank you, Ms. Binish. So the next question is from Professor Zakir Hussain Parray. What opportunities exist for cross-border collaboration to enhance surgical technology, education, and research? Mr. Zakir.
Hello.
Yeah. Yes, Mr. Zakir, we can hear you. Mr. Zakir Hussain, are you here? Sorry, I think due to connection issues, he's not here. So we can move on, Mr. Hafiz, to Mr. Hafiz Abdul Mannan Sahab. Mr. Hafiz Abdul Mannan Sahab, how do you suggest improving global standards and certification for CSD technician working in low middle income countries hospital? Mr. Hafiz Abdul Mannan.
Very thank you so much, Mr. Raza, for my second question. Actually, my question about global standard and certification in CSST technicians for CSSC technician or CSSC staff regarding low and middle income countries. First of all, we should create a global core framework adaptable to local resources. For example, if I discuss New Zealand, Australia, USA, they follow the AMI standards, HSPA standards, CBSPD standards, and also AS5369 standards. But in low and middle income countries, there is not too much good income resources. They facing too much problems. They didn't have a good equipment and machines and barcode system. And I think I already discussed they should go to World Health Organization standards, WHO. And also, I already discussed they should make a chapter like Pakistan, India, and other countries make a chapter with CPSPD, HSPA, and they should make a standards. And second, my opinion, first of all, CSSC recognized as a clinical department. It is not a kitchen or dishwashing department. We hire a staff. They only use water and soap to clean the instrument. It has a too much long story, and they have a too much deep knowledge. And it is necessary to understand the CSSC technician staff. They should give first of all the respect of the CSSC staff. Uh, uh, if we adopt the CSSC staff as a clinical department, as a clinical technician, then we give respect as they like a nursing staff and other technician staff. And we emphasize their education, their certification, their training, their courses, so they can get improve their skills, how to clean the surgical instrument, how to disinfect the surgical instrument, how to wrap the surgical instrument or pack the instrument, and how recall the system for sterilization set. So it is my humble request to all staff who are listening by this talk. We should emphasize the CSSC staff for the education, and if they get a good education and certification, definitely they give a very good product like in the form of sterilized set. Some people maybe understand CSS staff has a mysterious room. Their instrument disappear, and after magical they come back again sterilization. It is not possible. They have a long process like cleaning, disinfection, sterilization. Then you get a set. So this point was I discussed for the improvement in global standard and certification. Very thank you so much.
Okay, thank you, Mr. Hafiz Abdul Mannan. So I would like to ask Mr. Junaid Khan, how can we ensure sustainable training for robotic and advanced surgical technologies in resource-constrained setting? Mr. Junaid. Mr. Junaid, are you here? Okay, so we can move to save the time. We can move to our next panel member, Mr. Muhammad Akhtar. Mr. Muhammad Akhtar Sahab, can you give insight on what innovation in workflow management and sterile processing have had the greatest impact on patient outcome in your experience? Mr. Muhammad Akhtar, are you here with us? I think due to connection issues, he lost the connection. So, Dr. Zakir, Mr. Junaid, have you joined back?
Yes, I'm back. Thank you so much.
Okay. So, Mr. Zakir, my question is to you. What opportunities exist for cross-border collaboration to enhance surgical technology, education, and research?
Okay. Thank you for the question. The question is like opportunities exist for cross-border collaboration to enhance surgical technology, education, and research. Firstly, I like to say it in this way, like in the field of surgical technology, collaboration should not be confined by geography. Patient safety is a global issue, and so the need for well-trained surgical technologists, cross-border collaboration provides us with unique opportunities. Firstly, I like faculty and student exchange programs, which build exposure to diverse practices. A technologist trained in infection control standards in Europe or simulation labs in United States bring back knowledge that can uplift standards in their home country and vice versa. Secondly, I'd like to say joint research initiatives can accelerate innovation. For example, multi-center studies on surgical site infections or evaluation of new sterilization methods are stronger when data comes from varied healthcare systems. Similarly, collaboration on emerging technologies like surgical robotics or teleanesthesia can make cutting-edge research accessibility globally. The third thing is that digital learning platforms and virtual simulations break down barriers. Today, a technologist in India can participate in the same simulation-based module as a peer in Canada, USA, any other states, with both receiving standardized training in patient safety. Finally, I can say that there is the aspect of global harmonization of curricula and accreditation. If we can align competencies internationally, much like nursing and medical education bodies are trying to do, it ensures that no matter where a technologist is trained, they meet a baseline standard of safety and competence. So, cross-border collaboration is not just about exchange; it's about building a global workforce of surgical technologists who can uphold the same patient safety standards, whether they are working in Bangalore, India, Boston, or Berlin. Thank you so much.
Thank you, Mr. Zakir. Nicely respond. Uh, so, Mr. Junaid, are you here? Mr. Junaid and Mr. Akhtar?
Yes, sir, I am here.
Okay, so I would like what innovation in the workflow management and sterile processing have had the greatest impact on patient outcome in your experience?
Thank you, Mr. Raza. So, as a theater manager back from Pakistan and here in Kuwait, so there is some innovations that is may be required. That is the first one is an instrument tracking system and barcoding. And second is the adaptation of advanced sterilization techniques. As Mr. Mannan said, there is too much advancement. So third one is the lean workflow models like case cut system as discussed earlier. So first I would discuss instrument tracking system and barcoding. The introduction of instrument tracking softwares and barcoding system has reduced the error in tray assembly and improved accountability. This ensures the right instrument reach the operating room on time, minimize the delay and risk of contamination. And second one is the adaptation of advanced sterile techniques. So low temperature sterilizations methods such as hydrogen peroxide plasma and vaporized hydrogen peroxide have allowed for safe sterilization and delicate heat sensitive instruments. This reduce the risk of surgical site infections while preserving instrument integrity. And third one is
Thank you.
it's okay. Thank you so much.
Okay, thank you. So I would like now ask from the participant if there is any questions related to our panel member. Now we are open for the questions. Any question, you can type in the chat box or you can ask here. Any question? We are open for the questions. You can type in your chat. box, or you can ask here directly. Okay, so thank you all. Today's session on innovation, future direction, and capacity building have given us very clear direction and three clear takeaways. The one, quality and safety must guide all technology adoption. Education and cross-country learning are the key to progress. And we must future-proof the surgical workflow to meet tomorrow's challenge. So now it's all from our side, and I would like to invite the chairs and the host. And I would like to sincerely to thanks to all our panelists for their great insight and contributions. And I would like also thank you to the audience for your engagement. Uh, you may ask questions related to this. So that's all from our side.
I want to say something.
Yes.
For a minute.
Yes, Ms. Beenish.
I want to say thank you to Adi Busola, the CEO of the Operating Room Global. I really appreciate your massive efforts that you're putting in interprofessional education, and you're actually combining all the disciplines from surgery, anesthesia, surgical technology, and nursing. It's a big achievement, and congratulations on organizing this big event, this big conference. You're actually working very hard. You are actually a mentor for us. Thank you very much.
Thank you. Thank you. Mr. Samuel, over to you.
Thank you so much, Dr. Raza, for that excellent moderation. Here we come to the end of our first panel discussion, and we finish much earlier than expected. We have about 8 minutes before our lunch break. So I'll give anyone the opportunity to maybe share their thoughts or ask any questions if they have any, while we slowly get to the breakfast time. So is there anybody who would like to say something? Maybe from their personal experiences? Okay. In the absence of any questions, here comes breakfast. And see you back at 8:55 for the next session.